So let's start with the first. My name is Gil Bolotin from Israel, and let's start with red cold distribution width to parallel ratio related to cardiac surgery. The first speaker is here. Please.
Sorry. Good afternoon, everyone. My name is Li Zhaoxi. I'm from Central China Cardiovascular Hospital, Zhengzhou University. I wanted to talk about red cell distribution-wise to platelet ratio is related to CSA-AKI. Cardiac surgery-associated acute kidney injury is a common postoperative complication. It not only elevates the risk of morbidity and mortality, both immediately after surgery and for years to follow, but also imposes a significant economic burden. The red cell distribution-wise to platelet ratio is a calculated metric from a simple peripheral blood test, making it easily accessible and inexpensive. Importantly, it has proven to be a useful predictor for outcomes to patients with other conditions, such as heart failure and acute coronary syndrome. Based on our inclusion and exclusion criteria, we recruited 252 patients from our center undergoing cardiac surgery with cardiopulmonary bypass from 66 years old to 84 years old. Then we collected their inpatient and surgical data. We defined the baseline creatinine levels at the first value measured at admission. Then we diagnosed the AKI by applying for the Kegel criteria to several creatinine measurements taken every 24 hours during the first 7 days after surgery. That includes comparing the dynamic changes in creatinine and its further increase from the baseline. And we also compare the baseline characteristics using a significance level of the p-value less than 0.05. We identified statistically significant indicators to serve as covariates. Finally, we utilized the logistic regression model with RPR in an independent variable and AKI in a dependent variable. We found that for every unit increased in RPR, the odds of developing AKI increased by a factor of 1.433. The model shows excellent predictive performance with an area under the curve value of 0.855. Our results demonstrate that the model incorporating RPR and CRP exhibit exceptional discriminatory power with an AUC of 0.9931. And the model incorporating RPR, CRP, and BUN exhibit with an AUC of 0.978. All test results were in compliance with the requirements, so RPR may serve as a simple and accessible auxiliary biomarker for identifying AKI. But we also need more larger prospective multi-center studies to confirm these results and establish the clinical applicability of RPR before it can be formally adapted into routine practice. Thank you.
Thank you very much. Any question from the podium? Since we are a little bit late, thank you very much.
Thank you.
So the next presentation is sex differences in arterial grafting survival benefits in dialysis patient undergoing coronary artery bypass grafting, and Christine Young. Please. This is your presentation?
presentation?
Yes.
So maybe just go there.
Oh, thank you so much. Hello, my name is Christine, and I'm a fourth-year medical student at Columbia. Today, I'll be presenting our study on sex differences and arterial grafting survival benefit in dialysis patients. 800,000 people in the U.S. live with end-stage renal disease. Cardiovascular disease is the leading cause of death in these patients. While revascularization has been shown to prolong survival in these patients, they also have increased morbidity and mortality when undergoing CABG. Use of arterial grafting has been shown to prolong survival in this population. However, in the general population undergoing CABG, female patients tend to have worse outcomes than male patients with or without arterial grafting. Given the higher morbidity and mortality, as well as the decreased life expectancy for the dialysis patients, it is not clear whether these sex differences persist as they do in the general population of CABG patients. For our methods, our objective was to compare in-hospital mortality and long-term survival by patient-reported sex, stratified by conduit choice into 3 groups: vein grafts only, use of the lima with other vein grafts, or multi-arterial grafting. The data comes from the United States Renal Disease Database System from 2015 to 2020, and the primary endpoint was 5-year survival. We used inverse probability treatment weighting to balance the cohorts. When we compared lima versus SVG only and lima versus multi-arterial grafting for men and women, we found that for both men and women, there was significant survival benefit for lima over vein only, as expected. However, there was no significant difference for multi-arterial grafting over lima in either men or women. The numbers were small. We then compared the survival of men and women directly by conduit choice with sensitivity analysis for hospital survivors receiving lima. We found that men had significantly better 5-year survival than women for lima hospital survivors, and multi-arterial grafting, but no significant difference for vein only. In conclusion, 5-year survival among dialysis patients remains dismal, but both men and women experience significant survival benefit for lima over vein only. Populations are small, but there was no detectable survival difference from multi-arterial grafting over lima in either men or women. Similar to the general population, men had significantly better 5-year survival compared with women when undergoing any arterial graft, with no significant difference in vein only. Future work, such as the Roma Women trial, is needed to better characterize the effect of arterial grafting in women compared to men, and to better guide conduit choice and patient selection in this unique and highly morbid population. Thank you.
Thank you very much. Any questions? Thank you very much. Next presentation, prognostic value of myocardial viability assessment in patients undergoing coronary artery bypass grafting, a meta-analysis. Zander. I pronounce right your name?
Zander Jacquemin, yes. Hello everyone, I'm Xander Jacquemin. I'm a postdoc associate at the University of Pittsburgh Medical Center, and I'll be presenting myocardial viability in patients undergoing CABG. I have no conflicts of interest. So CABG improves survival in ischemic cardiomyopathy, but not all patients benefit equally. The role of viability imaging in this population remains debated, so I wanted to evaluate whether myocardial viability predicts better survival after CABG in a pooled analysis. So we performed a study-level meta-analysis of 8 studies, over 1,200 patients, and we performed statistical analyses. We included 8 studies, all observational in nature. One was a post-hoc analysis of a randomized controlled trial of STITCH, and the mean age of the patients was around 60 years old. Men were overrepresented, and there's varying viability definitions if you look on the right-hand side. So it's either based on CMR, based on scarred myocardium, non-viable segments, presence of LGE, and also FDG PET radionuclide imaging. So when we look at the overall survival over a 10-year time period, you find that patients with viable myocardium have around 40% risk reduction compared to patients without viable myocardium. Then we aim to perform a comparison between CMR and radionuclide imaging, and we found that there's, in both groups, a statistically significant reduction at around 40% for CMR compared to around 33% for radionuclide imaging. With an interaction model, we found that there is no significant interaction between the two modalities, which means that the benefit is equal if you measure it in CMR or in radionuclide imaging. We performed the conventional 2-stage meta-analysis as well, using the 4 spots which you can see here, and the results are largely consistent. We performed several sensitivity analyses, and we found no publication bias. If we iteratively excluded each study, we also found that the results were maintained, so very robust evidence that we can see. So in conclusion, the presence of viable myocardium has better survival after CABG. This supports the use of viability imaging for risk stratification, and more prospective studies are needed. Especially, I also want to raise the question that they raise the point that there needs to be standardization of viability definitions and thresholds. Thank you so much. Any questions?
Thank you very much. Any questions?
No?
Did this influence your practice?
It does not. We know that viability imaging is underused, and also this study doesn't address whether you should do a CABG on a patient or not. So because, for example, in the Stitches trial, it was medical therapy versus CABG in patients with viability they evaluated. But this study only looks at patients who were ultimately selected to go CABG. So it's kind of like a prognostic effect. We see that patients with viable myocardium have better outcomes, but it shouldn't influence your practice to determine whether or not you should perform a CABG. That is more prospective and randomized data needed.
Thank you very much. So the next, number 4, rapid discharge after off-pump coronary artery bypass grafting, how safe it is, a propensity match study, Ganesh Kumar. Please.
Yeah, good afternoon, everybody. So the topic of my focus is ERAS, so rapid discharge after OPCAB. How safe is it? A propensity match study. So I do not have any disclosures to make. So while very early discharge, that is in 4 or under 4 days after a full sternotomy OPCAB is well known, proven safe, cost effective, and not novel, but the term rapid discharge to indicate discharge less than or at 2 days has been put forth more recently. Its advantages can be profound, especially in resource-starved setups faced with very high patient backlogs. So this is the first study till date aimed at validating the feasibility and safety of such consistent rapid discharges after conventional full sternotomy OPCAB, obviously in suitable patients meeting prerequisite criteria. So the methodology of the 1,268 CABGs who had undergone full sternotomy OPCAB operated by a single surgeon in 3 different centers between May 21 and April 25 were studied retrospectively. 386 cases that were managed with ultra fast track protocol met the criteria for rapid discharge and were compared with conventional discharges. Furthermore, a propensity score model was constructed to overcome the baseline differences between the 2 study groups. And the results, propensity score matching analysis yielded 235 pairs of rapid discharge cohorts, and all endpoints were compared. So the in-hospital mortality rates and the 30-day mortality rates were comparable in both the arms with no statistical difference. Mean time to extubation, time to mobilization, time to discharge were significantly shorter. That is the mean time to extubation, roughly 147 minutes as compared to 323 minutes, and time to mobilization about only 15.6 hours as against 32 hours, and time to discharge about 41.8 hours versus 103 hours, were all significantly shorter with p-value less than 0.001 in the rapid discharge group. But the need for hospital readmission within 30 days, though, was slightly higher, 1.7% versus 1.28%, but despite this, it was not statistically significant, p-value of 0.7. And the overall survival and freedom from cardiac death at 1 year, and both the groups were again similar with no statistical differences. So to conclude, the present study is the first study till date analyzing the effectiveness of rapid discharge after full sternotomy OPCAB, and ERAS being a multidisciplinary approach that holds great value in judicious utilization of resources while optimizing patient care. However, sufficiently powered studies are required in the future to confirm its longer-term outcomes. Thank you.
Thank you very much. Any questions? Yes, please.
Was there any extra visit reserved for that kind of patient that was discharged?
Yeah, for the earlier set of patients, we had a remote monitoring device, the biosensor, which gave us a continuous monitoring. So for the initial set of 50 patients, we actually had a continuous feedback, as in twice daily phone calls from the department. So, and later, once we got confidence, we went ahead with it because it was working.
Did you check patient satisfaction, or if there is any support at home or something like this?
Yeah, the prerequisite criteria for discharge were all that the drains should have been out in the first 24 hours, or at least the first day. And that was the first surgical point of view. Second is no new onset arrhythmias, no new onset atrial fibrillation, and also non-requirement of any inotropes at the end of day 0. And also no laboratory parameters which are trending abnormally higher, like the total counts or the neutrophilia or even lactate or CRP. So these were some of the laboratory parameters as well we took care of. And satisfactory analgesia also being an important factor.
Thank you very much.
Thank you.
The next one is 10 years outcomes of coronary artery bypass grafting versus percutaneous coronary artery intervention in patients with 3-vessel disease and heart failure. Jimmy Kang. Missing. So we go for the number 6. Sternal complication rates and healing with wire cerclage. Pooled analysis from 3 randomized trials. Kate Allen.
All right. Well, thank you all very much. On behalf of my co-authors, I want to thank the ICC for the opportunity to present this pooled analysis from 3 randomized trials. These are my disclosures. So this should be a never event. Unfortunately, it's not a never event. So sternal complications do occur, and while this is a very rare complication that resulted in the death of this patient, we think sternal complication rates are actually underreported. When you look at the current STS definition, it really looks at only deep sternal wound, and it's a self-reported registry only out to 30 days. It excludes superficial wound infections, sterile dehiscence, implant failure. We did a pooled analysis of 214 patients from 3 randomized controlled trials conducted at 19 centers in the US that randomized patients to wire cerclage versus plating. And all 3 of those studies used the same sternal complication definition, which included not just deep sternal wounds, but also superficial wounds, sterile dehiscence, implant failure, and obviously this is prospectively collected and managed as part of RCTs, not out to 30 days, but out to 90 days. All 3 randomized trials utilize similar endpoints that have been previously published, which included core lab blinded CT scan evaluation for bony union, any sternal complication, pain scores, and patient-reported outcome measures, including quality of life. When you looked at sternal complications at 30 days in the 209 patients that were alive, it was 2.9%, much higher than what people talk about it being less than 1% from the STS. And when you carry that out to 90 days, that complication rate, all inclusive, was 3.8%. 25% of complications occurred after the traditional 30-day reporting period, and sternal complications through 90 days in these 3 trials resulted in 16 reoperations in 8 patients. At 90 days, only 15% of patients exhibited sternal union based on an a priori defined CT scoring system. Older age and higher BMI predicted lower sternal healing scores by CT. And in addition, there was a strong correlation between sternal healing and the probability of being pain-free at 90 days, both at rest and after coughing. So in conclusion, when prospectively evaluated as part of an RCT, wire cerclage demonstrated higher sternal complication rates than are typically reported in the traditional 30-day STS model. Optimizing sternal closure beyond wire cerclage, particularly in higher risk patients, should remain a pertinent goal of cardiac surgeons. Thank you.
Thank you very much. I think it is a very important message because I think it's under, the truth is there is much more sternal wound infection in the United States, and it's just underreporting because of the never event decision. So it's probably what you suggest, it's just the tip of the iceberg, and there is much more sternal wound infection in the United States than what we know about. This is what happened in the other world, and it's probably the same in the United States. Thank you very much.
Thank you.
The next is number 7, variability in aspirin response during early post-CABG recovery. Anna Kezzoli.
That's fine. That's me, Kenzora.
Va bene.
That's actually hard. Okay, I think I'm fine. Yeah. Hi, everyone. Okay. My name is Anna Kenzora. I represent a multidisciplinary and multi-institutional research team from Poland. And today I'll tell you how much we actually don't know about the postoperative aspirin yet. So first I'll tell you a few things about what does current research really tell us about aspirin dosing early after CABG, what is novel about this preliminary analysis and about this project, and what are the potential future directions in research about aspirin based on this preliminary study. So what the guidelines actually tell us is, well, they're very clear that we shouldn't discontinue aspirin preoperatively and that we should continue it postoperatively at a low dose. But in fact, the initial aspirin study after CABG that proved its beneficial effect administered a wide range of aspirin doses ranging from 80 to 650 milligrams within the first 48 hours after the surgery. And the matter is so unclear that we actually have an upcoming RCT in Poland that will be a multi-center randomized controlled trial. And we will randomize patients to receive high-dose aspirin, low-dose aspirin, or dual antiplatelet therapy for 3 months after CABG. And this RCT that was funded by the Medical Research Agency in Poland is driven by the potential impact of surgery. And that's a phenomenon that has been already established in the literature, that there is some aspirin resistance after coronary artery bypass grafting, and that platelet function may be actually impaired by the CPP itself, and that there may be increased turnover in platelets and increased reactivity. However, the methodology in both of these studies was based on preoperative discontinuation of aspirin, which no longer reflects current medical practice. What's novel about this project that I'm telling you about today is the fact that we analyzed the response to aspirin treatment with either 75 milligrams or 150 milligrams daily without the preoperative discontinuation, and that we analyzed our data based on the individual patient's level. Sure, we have some limitations. The first one, that's a very small sample size. We only have 40 patients. That was like a starting research grant. This is an observational and exploratory design, so no randomization to aspirin doses was performed. The analysis plan for this study was that we took blood samples from 40 patients who underwent on-pump CABG for chronic coronary syndrome, so those were elective cases. And then we tested them roughly 5 to 7 days post-operatively. And these patients either received 75 milligrams or 150 milligrams of aspirin based on the surgeon's decision. The key finding of our preliminary analysis is that there is a significant difference in the variance of the aggregation induced by a stimuli. This difference in variance, it's not only the difference in the mean value, but it's actually the difference in how widely the value is spread. And this was driven by the fact that in the low-dose aspirin, there were either patients who responded well to aspirin or patients who did not respond properly or as expected. So the pattern of the response was binomial, and that's something that hasn't been published before. The potential causes are only our initial hypothesis, and those are increased platelet turnover after the surgery or impaired absorption in the early perioperative phase, but we haven't really tested for that. And this will require another prospective observational design. And for sure, definitive answer about the clinical effect of the dose of postoperative aspirin will require a randomized design with a clinical endpoint and power calculations. Lastly, I would like to acknowledge the Polish National Science Center, which funded this grant, and the Founders Fellowship Award that allowed my attendance to this conference. Thank you for your attention.
Thank you very much. Any questions? So at the moment it's mainly laboratory, no clinical evidence.
Yes. Yeah, that was only a laboratory marker.
Okay, thank you very much.
Thank you.
Number 8, suture versus ring annuloplasty in surgical management of ischemic mitral regurgitation on a comparison study. Abdul Son. I guess we can slow the rate. Now the next one is number 9. A novel bioengineering tissue conducted in coronary artery bypass grafting, a first-in-human study. Matthew.
Thank you. Let me find it here quick.
Yeah.
Okay, thank you. I'm a cardiac surgeon at the University of Minnesota. I'm here speaking on behalf of Vascudyne regarding novel bioengineered tissue conduit for use in coronary artery bypass grafting and some of our early first-in-human results. So I'm a consultant. My co-authors work for the company. So Vascudyne has been able to use unique bioengineering technology to create acellular tissue engineered vessels that can essentially come off the shelf. These are created from human fibroblasts that are essentially embedded in a nutritive scaffold and can be grown in sheets or in tubes, as is relevant for this discussion. This is regenerative, meaning in preclinical studies we show that in animals these conduits endothelialize and actually have migration of native cells along the length of the graft, essentially suggesting that it starts to transform into the patient's own native tissue. And to date, animal and human studies have shown that these are non-immunogenic. Essentially, after the conduit is created, it's decellularized, and we have no evidence to support there's any antigenic response from the immune system in any of our implants in animals or humans to date. The current iteration of the device utilizes an external nitinol support structure to mitigate some of the risks of early kinking of the device, given that it has predominantly collagen structure. So in the dynamic environment of the pericardial space, it was noted in preclinical models that graft patency in the early term could be compromised by distortion of the conduit, and with initiation of external support structure, the preclinical patency in ovine models optimized to 100% patency. And those animals are followed out to at least, well, we have animals out to 18 months. So our first in-human implants were these two patients. Both of them received a left internal mammary artery to left anterior descending artery, and one of them received our conduit to the right side and the other patient to the left side, and the third bypass for each patient was native saphenous vein. These patients were initiated on aspirin therapy postoperatively and then onto apixaban prior to discharge, with the expectation that there's some early thrombogenic risk until this device endothelializes. But again, in animal models at least, these grafts endothelialize within about 6 months. And these are postoperative CT scans showing that the lemmas are patent in both of these patients, our conduits are open in both of these patients, and that at least 30 days, the native saphenous appears to be open, although the patient with the saphenous to the right appears to be developing a string sign. And so at 6 months, we see that the acellular tissue conduit is open in both of the patients, both to the diagonal branch and the distal right coronary. And in the saphenous vein grafts in those same patients, we see a string sign of the saphenous vein to the right and a distortion of the distal anastomosis probably related to excess graft length in the other patient. At 1 year, there was no MACE. On incidental follow-up, it was noted that the patient who had their ATEV to the left side of the heart, that there was likely a size and external support mismatch that led to a similar distortion in the proximal anastomosis that was maybe noted on 6-month imaging, but probably led to loss of patency between 6 and 12 months, essentially as a technical issue, but that the patient with a good technical outcome and graft length sizing, that we have 1 year patency rate in that patient. So, as of now, out to a year, we have this patient with an open conduit, no MACE despite that one graft closure. Again, this avoids additional surgical site, can potentially pull a conduit right off the shelf, lessens overall recovery, and ultimately widens potential patient base who maybe don't have autologous vessels or potentially, depending upon future studies, may indicate that the patency of these may be preferable to autologous saphenous vein. We have an ongoing trial, phase 1 trial in Europe, where we've had 5 implants to date, and are working on starting some early trials here in the US, but obviously more to come.
Thank you very much. It is a very important issue that is working for many years for this wave, but 50%.
Yeah, I think it's very clear that it was a technical issue with the implantation. The first in human were essentially feasibility. I think that the early trials were really trying to stratify patients who don't otherwise have a good option from a conduit perspective. And then ultimately seeing how that performs. Our hope is ultimately to have comparative data versus saphenous vein, because obviously even within the patients that we did, we had a saphenous vein closure and one stenosis. So I would say actually we have better outcomes than saphenous vein in those 2 patients. But ultimately that's why we need bigger trials. I think the regenerative nature of this opens up a lot of potential possibilities for patients who otherwise don't have good options from a conduit perspective. And we may yet see that this outperforms saphenous vein.
Thank you very much. Any other questions? Thank you very much.
Thank you.
So we are now in number 10, ticagrelor removal to reduce bleeding after urgent CABG, comparative analysis in real-world data. And the presenter is Michael. Mike, how are you? Please.
First of all, I want to thank the society to...
Escape again.
Yeah, first of all, I want to thank the Society to present our data here today. And secondly, I want to specifically thank Jill that you spontaneously jump in and serve as a chair. So the title of the talk, as you already mentioned, is Ticagrelor Removal Intraoperatively and a comparison with real-world data. And also in the prior talk, we heard about postoperative anticoagulation. But what would happen preoperatively if you have to do emergency CABG surgery in patients on ticagrelor or any kind of P2Y12 inhibitors? And there was just recently a big meta-analysis being published with more than 4,800 patients, and they could prove in this meta-analysis in isolated CABG patients who couldn't wait for the washout that the bleeding risk is doubled. And they did multiple regression analysis, and that was proven. So our idea was to compare the results, because there is a new tool being available which can be integrated. It's a kind of adsorber in the CPB circuit. And this adsorber is capable to remove hydrophobic substances up to 60 kilodaltons, which is true both for DOACs, so rivaroxaban, apixaban, edoxaban, dabigatran, but also for ticagrelor. It's approved in Europe and worldwide. It's still under regulatory review in Northern America. And we have more than 300,000 safe treatments so far. So we aimed to compare two cohorts. And the first cohort comes from a registry, the so-called STAR registry, the Safe and Timely Antithrombotic Removal Registry, isolated CABG patients who were unable to wait for washout. So the washout period was less than the guideline recommendation of 72 hours. And we could include 150 patients here, and they were matched by inverse probability testing to a second cohort coming specifically from this study I already mentioned, with no device. All emergency isolated CABG patients from this meta-analysis, so 389 patients were matched on a patient level. Doesn't work. So this here are, this slide shows the perfect matching. So our aim was to result with a standard mean difference of less than 0.1. So all parameters have been below that threshold. And the next slide shows the outcomes. So on the left, you see the BARC4 bleeding events. So the Bleeding Academic Research Consortium Class 4, which is the grading for isolated CABG surgery. And if you compare the device group of 150 patients, the bleeding results are roughly around 14% compared to 40% in real-world data. And we did also a sensitivity analysis, including 30-day mortality, and the results remained consistently being significantly different. So I want to conclude, BARC4 bleeding occurs in about 1/3 or even more in patients on ticagrelor without a guideline-recommended washout period, undergoing isolated CABG surgery. There is a new tool of intraoperative hemoabsorption that can remove ticagrelor and could significantly reduce BARC4 bleeding events. Of course, we need more randomized trials to validate those findings, and I can tell you that the randomized trial has just been accepted for publication in JTCPS. Thank you for your attention.
Thank you very much. Any question for? So what is your practice now? If a patient needs urgent operation before the 3 days?
I would definitively implement this device. It's easy to use. You can implement it in any kind of extracorporeal circulation. For DOACs and for ticagrelor, I would definitively recommend to use this device intraoperatively.
Thank you very much. Next one is number 11. Clinical outcomes of external saphenous vein graft stenting in coronary artery bypass surgery, the RESTART study. Luca, please.
Thank you, Gil. Let's look for the not so easy. Yeah. Good. Okay, thank you so much. I'm very glad to be back in New York to present. It all started here in 2019. And at that age, I presented what was a vision, an intuition about the possibility of systematically using something to enhance the patency of the saphenous vein graft. And 6 years later, something has blossomed. We all know that we have two ways our grafts, our saphenous grafts do fail. An early stage, which is due mainly to technical error, or kink, or compression, these sort of things. And the vast majority of failure are late failures and are due to lumen irregularities, intimal hyperplasia, and atherosclerosis. Now, there is something out there that promised to change this and to some extent has delivered. It's called VEST. It's a cobalt chromium external support. You can imagine it, if you've never seen it, as an external vest for an external stent for the vein. It has some radial elasticity. It is kink and crush resistance. It has axial plasticity. You can milk it up to 23 centimeters and maintains its in situ configuration without fixation. The proven effects on saphenous vein grafts are reducing lumen irregularities, reducing wall tension, reducing size mismatch versus native coronary artery, and preventing vein dilatation, but of course will not rescue bad anastomosis. This is what a finished implant would look like. You see how it sticks to the vein, adhering, and it makes basically the holy grail of what we've always looked for, the third layer of a vein, making it close to an artery. Now, the evidence about the VEST has piled up in these years. We have over a decade of robust clinical researches, and up to a certain point, we had also randomized control trial consistently demonstrating biomechanical effects in terms of reduction of intimal hyperplasia and lumen irregularities. This is a fact, it's not anymore a promise. But what we really need is the impact in the clinical settings, and I'm proud to present here a couple of freshly published papers. The first one is called the Restart. What we did is we joined forces, 6 centers all across Europe, Germany, Italy, Switzerland, Austria, UK, and Israel, and matched this with the ART cohort, and therefore we had 3,000 patients to match with our nearly 1,000 patients. And when you have this sort of number, you can probably say something significant. We chose ART as a comparator because it was what we had, being Taggart part of the study, but also because it's a tough comparator. It's not the most up-to-date comparator, but it's one of the studies with the best results. So if we can make it there, we make it anywhere, as the song says. These are the results. Match endpoints at 1 year consistently spread out, but even more importantly, look the results at 5 years. The two curves diverge. And as a former professor of statistics, when I see two confidence of interval not even crossing on the graph, I don't look any further. This is solid evidence of a difference in terms of treatment. At the granular level, if you look at the revascularization rate side by side, when you implant the vest versus when you do not implant the vest, you have a significant difference. So it is really making a difference, and in the last 30 seconds, I just go on presenting another real-world evidence. This is a multicentric studies with Vienna and Torino and Rome, prospectively followed up our 400 patients, and we found very similar results. The revascularization rate fell from 4.32 to 1.28 when we used the vest. So we have a proven biomechanical effect, but now we have a convincing clinical evidence that we can do something to enhance our vein saphenous. Thank you for your attention.
Thank you very much. Any questions? So which vessel you prefer to use this device, in which grafts?
Personally, due to financial constraint, I tend to perform all my anastomosis in a sequential fashion. Therefore, I use it on the proximal part, where most of the shear stress is also on the impact of the pulsatility.
Okay, so I can add that as a user as well, I use to the left side the arterial graft, and I use it always to the right vein, to the right side. So thank you very much.
Thank you.
Hi, nice to see you again.
Yeah.
It's a long name for the presentation. Surgical versus percutaneous revascularization in patient with multivessel disease and non-ST segment elevation, acute coronary syndrome, meta-analysis from 77,000 patients with reconstructed time to event data. Ahmed Awad.
Yes, I can find the...
From Cleveland now.
Yes, sir. I can't find the presentation. They haven't put it over here or like...
You found?
No. Let's see, like...
Okay, let's close it.
Close all?
Yeah, just close the... and now we find it here.
Okay. Yeah.
No, just... yeah.
Okay, perfect. So thank you, Dr. Galata, for the introduction. And I'm Ahmed Awad. This study has been conducted when I was practicing in Egypt, and now I'm a research fellow at the Cleveland Clinic. I would like first to thank the International Coronary Congress for the opportunity to present our work at beautiful New York and the best time of the year. I have no disclosures, unfortunately, but let's go. So multivessel coronary artery disease is defined as a significant stenosis in two or more major epicardial coronary arteries, and it's present in approximately 50% of the patient with acute coronary syndrome. The current 2025 ACC and AHA guidelines recommend complete revascularization in patients with ACC and multivessel, but the current guidelines also doesn't specify a clear preference for those who has multivessel disease with non-ST segment elevation acute coronary syndrome. So non-ST segment elevation acute coronary syndrome with multivessel disease represent a complex clinical scenario where optimal revascularization strategy remain a debatable area. And this was the goal of the meta-analysis that we performed. So we searched the regular databases, PubMed, Embase, Web of Science, and then our inclusion criteria were any study that has the population as multivessel disease and non-STEMI acute coronary syndrome, ACES, and the intervention in those studies are CABG, and the control is the PCI. We haven't focused ourselves on only the RCT, we only expand and to include all the observational studies as well. The primary outcome was all-cause mortality in 30 days and the long-term survival. After screening, we ended up with 17 studies, and these are the baseline characteristics of the patient, like 77,000, nearly 78,000 patients were included, 52,000 patients in the PCI group and 25,000 in the CABG group. The mean age in both groups was nearly 62 years old, and then the mean LV ejection fraction was about 47.8 in the PCI and 43.6 in the CABG. We have to note here that the ejection fraction was lower in the CABG cohort. But the all-cause mortality for 30 days were equal between the two groups, not statistically significant difference between PCI and CABG. That's also expanded to our secondary outcomes, which are the MACE, the MI, the repeat revascularization, and the stroke. This all at the 30 days. But a year at the outcomes were statistically significant, favoring CABG over PCI in terms of all-cause mortality, MACE, repeat revascularization, with no difference in stroke. Carrying this forward to the 5 years results, the CABG is winning, and then has a statistically significant lower risk for MACE, repeat revascularization. However, for stroke, CABG was associated with increased risk over PCI, 1.3 risk ratio. We did long-term survival Kaplan-Meier reconstruction, and we found that 15 years of follow-up, CABG was still associated with increase of increased risk of all-cause mortality over PCI, with 5 years survival of CABG is 88 and versus PCI with 84. 15 years survival for CABG patient was nearly 50%, was 46.3 for PCI. Of course, as in any meta-analysis, we have some limitations. Although we are the largest and the most recent meta-analysis about this topic, but majority of our included study were observational study. There were variation in the MACE definition across the studies, and for the syntax score, it wasn't reported except in 2 studies, which we believe if we reported in multiple studies, we can provide subgroup analyses that can force our message further. In conclusion, CABG and PCI have comparable short-term outcomes. CABG is still superior in the long-term outcome with the increased risk of stroke. So this all focus and emphasize that the need to deliver more durable care for the high-risk population. And if we want to eat the whole cake of the CABG versus PCI, we shall start with eating the small pieces first. That's it for today, and thank you very much. I'm looking forward for any questions.
Thank you very much. Any questions? So the next presentation is a national trends in urgent and emergency coronary bypass grafting. Matthew Patinari from Belgium. Close it.
No.
Good evening, everyone. So we would like to present here the national trend in urgent emergency coronary bypass graft. So there are limited contemporary data on the use of emergent and urgent coronary bypass graft, and those data originate mostly from retrospective single-center experience. So the aim of the study was to explore and analyze the results in urgent and emergent CABG at the national level in Belgium. So the data extraction was from a national voluntary cardiac surgery registry, and among nearly 10,000 patients operated from 2021 up to 2024, 3,300 were non-elective procedure. So in this group, 2,600 were urgent, 465 were emergent, and 149 were salvage. Here you can see the preoperative characteristic of these 3 groups of patients: emergent, salvage, and urgent. As expected, for sure, we have a difference also in percentage of male, age, several of these characteristics. The presence of NIA cluster 4, that was higher in the salvage group for sure. Also higher level of angina was also higher in the urgent group, and so on. There are several different characteristics in risk profile. Where the hemodynamic characteristics also were different as expected, because different presentation of the patient, with a poor left ventricle higher in the salvage group, pulmonary hypertension higher in the emergency group. The use of IV nitrate was similar between the 2 groups, and the shock was higher and the patient ventilated was higher, of course, in the salvage group. And here you see the coronary status of this patient, where a large patient with urgent case had a main stem lesion with about 50% of this. 3-vessel disease was higher in urgent and emergency case. It was relatively lower in the salvage case, and 2-vessel disease was also higher in the emergency case and urgent case. And here you see the major finding in mortality in this 3 group, with of course a higher risk in salvage group. In mortality, the up to 2 months was nearly 75%, while emergency case reached a mortality percentage of about incidence of 25% after 2 months, and the urgent case have a risk of about 2 to 5%. Here, more in detail, you see the mortality curve of elective case in red and the urgent case in blue. And you can see that the elective case has a mortality of about 1 to 2%, while the urgent case reach and increase the mortality up to 6%, let's say. But important also to notice, I think, in this curve of mortality, that the speed The inclination of the curves is different because the major risk for elective case is in the first months, while the risk of the urgent case rise up to 5 to 6 months. So the secondary outcome, we were really happy to see that apart from the operation for breathing, the stroke was very low in urgent case was 1%, was of course quite high in salvage, was 6% and 4% in the emergency case, so it remains a higher risk population when we operate on this patient. And to conclude, so more than 25% of CABG are urgent procedure and 5% are emergent or salvage. So as expected, non-elective procedure have higher 1-year mortality, and urgent procedure demonstrate low rate of CVA, reoperation, and hemodynamic support. However, peri and postoperative improvement at multidisciplinary level are imperative to improve mortality and morbidity in this high prevalent procedure. Thank you for your attention.
Thank you very much. Any questions? Any changes during the years, or it's, did you check whether it's changed in the decade or so?
No, this data is recent because it was a national project with outcome analysis and collection of data in the last year, so we don't have outcome similar for decades ago or more earlier.
Thank you very much. The next presentation is Tom Friedman from Haifa, Israel. The challenge of defining type 5 myocardial infarction after CABG, why cutoff fail, and rate of changes offer hope. A review.
It's a very long headline. Okay, hello. As Dr. Bolotin said, I'm Tom Friedman. I'm from Haifa in Israel, and I will present today the challenge of defining type 5 myocardial infarction after CABG, why cutoff of troponin fail, and the rate of change offers hope. Yeah. Okay. So as we know, the fourth universal definition of myocardial infarction defined type 5 MI as elevation of troponin more than 10 times the 99 percentile of upper reference limit for patient with normal troponin before surgery. But what is happening in real world? 2 years ago, we published a paper and we showed that 98% of the patients will have more than 10 times this URL. The average troponin after surgery will be 270 times the URL. The VISION study actually showed the same numbers as we did, or we showed the same numbers that they did. So maybe 10 times is not enough. Maybe we need to raise the cutoff. So the ARC group suggested to raise the cutoff for 35 times. The SKY group suggested to raise the cutoff to 70 times. And why do we have so many cutoffs or so many suggestions? So we have a lot of parameters that affect dramatically on troponin during surgery. For example, on-pump versus off-pump, different troponin levels post-surgery. If we have a concomitant surgery, if we have lousy cardioplegia and myocytes are dying, so we will have high troponin levels. And even if we are, for example, shocking the heart during surgery, it will raise the levels of troponin. So we were thinking about a better approach to see if we can use troponin to define type 5 MI. We took 153 patients that we had serial troponin levels for them after 6, 12, 24, and 36 hours. And we had documented cath or echo for them. 10 of those patients had documented MI in the cath lab. And when we were checking the rate of change for the troponin for those patients, we saw that we have a steep incline of the graph. While the patient that didn't have MI, you can see the graph was negative, and this was, of course, statistically significant. Why are we looking for all those MIs? I mean, some of them are silent. We know that 5% of the patients that will leave hospital, they will already have at least one graft that will be occluded. Gaudino and his group published 2 years ago in Circulation a big meta-analysis. They showed that after 1 year, 33% of the grafts will already be occluded. And we know today that all those graft occlusion, even if it's a silent graft occlusion, are increasing morbidity and mortality in the short and in the long term. So we think that by expanding our focus beyond 30 days mortality to examine whether dynamic troponin monitoring can identify silent graft complication, we may achieve a better understanding of graft failure as a predictor of future cardiac events and enhance long-term outcomes through early detection and targeted intervention. Thank you very much.
Thank you very much. Any questions? So what is the routine now in your department?
Yeah, so as you know, in my department, we're taking at least 3 troponin levels, and we are looking at the rate of change. The problem, we don't know what the rate of change that we are looking for, but we know if troponin will start, for example, 5,000, and it will be the day after 5,500, we feel okay. But if it's 5,000 and the day after it will become 10,000, then we are starting to be worried. But we are also we are sending patients to the cath lab very frequently. I mean, we don't afraid to see our mistakes, which most of us cardiac surgeons do.
Thank you very much. The last presentation of this by Jakub Zielinski, a relation between intraoperative flow parameters and arterial graft patency in computer tomography angiography assessment after CABG.
Good evening, everyone. Thank you for staying till the end. I want to start with the simple question. How many of you routinely perform follow-up CTA for your patient after CABG? Or it's still better to look into the crystal ball when trying to predict the future? I think it's still far from the routine practice. We've only recently started doing this ourselves. Our study cohort consisted of 91 patients who underwent total arterial CABG with the radial artery, followed by CTA. It means 90 months. This provides a robust data set of 189 grafts and over the 200 distal anastomosis, just to find some patterns. There were also additional findings. CTA, like a small lung tumors and some sternal dehiscence. A quick view into our group, mostly men in the mid-60s, with the usual set of cardiovascular risk factors like hypertension, diabetes, dyslipidemia. In the other ward, the typical real-world CABG population. The overall graft occlusion rate was 14%. As expected, Lima showed the lowest rate, while single radial artery had the highest. Rima group was too small to judge something. The leading reason for occlusion were not significant native stenosis and poor targeted vessels, notably radial artery graft to RCA, particularly in the context of chronic total occlusion, proved to be the most endangered. One of the clearest results, and also one of the most humbling, was not significant difference between flow meter value and long-term graft patency. As well, on-pump versus off-pump cabbage made no measurable difference in patency. It is interesting that the average flow in sequential radial artery graft is significantly higher than in the single graft, which may have some protective effects, although statistics did not confirm this. What does it mean for the practice? TTFM, good rather as a snapshot tool, but predictive value is limited. Post-op CTA provides essential information, often detects a clinical silent graft, especially beneficial for LAD. Another interesting observation involved graft revised intraoperatively. More than half of these were late found occluded on CTA. That suggests that the problematic graft we encounter during surgery often remain problematic in the long term and may demand closer attention. I want to finish with the line from William Osler that I think fits perfectly for our finding. Thank you very much.
Thank you very much. Any questions? So does this influence your current practice?
Yeah. All that patient were from my institution. Our finding motivates me to use CTA more frequent and evaluate our data and use the more often the radial artery grafts.
Thank you very much. Thank you very much, everybody.